This is a video of laparoscopic abdominoperineal resection for a case of carcinoma lower rectum. A 46-year-old lady presented with bleeding PR for 3 months and on evaluation found to have a T2 growth starting from 2 cm to anal verge to 6 cm and just aborting the internal sphincter. There was a clear CRM and there is 1 to 2 sub-centimeter nodes. So my plan was to go ahead with laparoscopic abdominoperineal resection as there is a very low lying growth. So ultimately the growth lower limit of the growth is just 2 centimeter from the anal verge. So I decided to go ahead with abdominoperineal resection. So after going inside, after ruling out any distant metastasis, I have started incising the peritoneum just lateral to the lateral aspect of the right side of the rectum, and then entered into the TME plane. You can see the vascular plane of the TME is entered, which is known as a holy plane of Hilt, and using sharp dissection using the hook, monopolar hook. The most of the majority of the dissection was done with monopolar hook. You can see the using monopolar hook with controlled energy application. Actually, we can get into the correct plane, the loose areolar tissue plane, where is you can see the loose areolar tissue plane. This is the plane between the fascia propria and the presacral fascia. So this is the correct plane of doing TME dissection, and with the assistant port good amount of traction is being given. So while doing the right sided dissection, the right ureter is being safeguarded, and medial to lateral dissection is being done to and safeguarding the left ureter also. And then the inferior mesenteric artery is being dissected all around at the root till the root, and all the fibrofatty tissue or the lymphnodal tissue was taken along with the distal aspect of the IMA, so that it will come out along with the lymph nodal tissue will come out along with the specimen. So here you can see the following the loose areolar tissue plane. I am doing the medial to lateral dissection just below and beneath the IMA, and majority of the fibroid tissue is taken to the specimen, safeguarding the hypogastric nerve plexus and the left ureter. Here you can see the movement of the left ureter, and I am staying well above the left ureter, safeguarding the hypogastric nerves. And medial to lateral, once the medial to lateral dissection is being done, the IMA is being dissected 360 degree all around near the root. So high ligation of IMA is being done using hemolock clip, and the IMA is being divided. So once the IMA is being divided, the further medial to lateral dissection is being carried out till the lateral abdominal wall is being reached. So you can see the ureter is being clearly seen in this picture. So safeguarding ureter is in this part of the dissection is very important. So you can see that we have from medial to lateral dissection we have reached the lateral abdominal wall. Now I have kept a gauge piece and we'll do the dissection. We'll incise the peritoneum on the opposite side, the peritoneum of the sigmoid colon, which is actually adhered with lateral abdominal wall. And once we incise this peritoneum, we will be able to merge the two planes from the medial aspect and lateral aspect into one. So here you can see the gauge piece that I have kept from the beneath the rectum. It is coming from the other side. So once we have opened these two planes and merged these two planes into one, so further dissection is being carried out in the same plane. So idea is to mobilize the descending colon so that we get a nice length for the end colostomy, and simultaneously following the TME plane on the left lateral aspect of the rectum, the further dissection on the lower down is being carried out a bit. And now you can see again the descending colon is being mobilized along with after the sigmoid colon is being mobilized, the descending colon is also being mobilized and staying away from the gyrotous fat. So the plane between the gyrotous fat and the mesocolic fat is being identified. So after mobilization of the descending colon, again the dissection is being carried out in the same TME plane. So this is on the posterior aspect of the rectum. You can see I'm gradually identifying the following the sacral hollow and gradually lifting of the peritoneum and staying into the correct TME plane. continuously, and there will be hardly any bleeding. You can see there will be little bit of small blood vessels you may encounter, but there will be no major bleeding. And the idea of staying into the TME plane will actually prevent the postoperative, I mean the intraoperative neurovascular injury on the presexual venous plexus or presexual nerves being safeguarded. Simultaneously, while doing the light lateral dissection, the light lateral ligament, while dividing light lateral ligament, the middle rectal artery is being also being divided. And you can see the lateral aspect of the rectum, the left lateral aspect of the rectum is being also mobilized, staying into the TME plane. And since this patient already underwent THBA, so there is no uterus here, and there was a little bit of addition of the sigmoid colon with the pelvis initially, so I have dissected, which is not shown in the video, but there was addition because of the previous pelvic surgeries. So I have already did the dissection, and now I am entering into the plane between the posterior wall of vagina and anterior wall of rectum. So it's dividing the rectovaginal septum, but staying into the TME planes anteriorly also, so that there will be no breach of the TME plane. And staying into the embryological plane will actually help me to yield maximum number of lymph nodal tissue, and that will harvest the maximum number of lymph node, and the oncological outcome will be good. So here you can see I am doing the dissection, carrying on the same dissection anterior to rectum, anterior to lowermost part of the rectum, and then the lateral aspect of the rectum also gradually being mobilized. The lateral ligaments were divided, so using harmonic shears it can be easily divided, and very cautiously. Sometimes it can after dividing the lateral ligaments it can bleed, so gradually and very slow and meticulously the rectum, lower part of the rectum is being mobilized and taken out of the pelvis. So you can see I'm trying to identify the correct plane in between. So staying into the correct loose areolar tissue plane, the further dissection is being done. So you can see the proper traction and counter traction is very important, and sometimes manipulation of the lower part of the rectum from below is also sometimes becomes very handy when you reach the lowermost part of the dissection. So here you can see I am doing the dissection on the dividing the lateral ligaments on the right lateral aspect. So here almost you can see the posterior vaginal wall here, and I am trying to mobilize the rectum, staying into the avascular plane, but without injuring the posterior vaginal wall. Sometimes there is chances of inadvertently injuring the posterior vaginal wall when it is densely adhered, and in that case we need to repair the posterior vaginal wall. But here in this case I got a nice plane between all these two. So this so this is the correct plane of dissection, you can see. So I am staying into the TME plane and doing continuous dissection to mobilize the lower part of the rectum and separating it from the vagina. So continuously adjusting my assistant port traction, so that it gives the correct amount of traction, and I can with my left hand instrument we can give the counter traction. So gradually almost posterior aspect I have already reached the dissected levator, and I dissected the plane up till the levator, and anteriorly also I am trying to reach the levator, and laterally also. So all around the rectum, all around the lower rectum, the levator is being dissected. So and then it is identified properly and nicely. So you can see how deep I am going with while doing this mobilization. So this is the plane which I went on to do the dissection in this plane. So once the lateral anterior dissection, the lateral dissection is being completed, now we can assess the proximal margin. So I can actually feel the while doing the dissection of the lower rectum, I can actually feel few nodes. This is one node, you can see one enlarged node that is being seen. And while doing the dissection, I can feel the tumor also. It was a bulky tumor in the lower rectum, reaching up to the anal canal. So without breaching the tumor, without doing any tumor perforation or any other adverse events, I went on to dissection, complete the dissection of the rectum from the levator. And you can see the levator muscle here, from which the rectum is being lifted up. So very carefully and gently the dissection was maximum amount of dissection is being done through the through laparoscopy, so that while doing the dissection from the perineum, the minimum dissection is being carried out. So now little bit of anterior dissection is being left, so I'm just trying to separate it. So this part of the dissection is probably the most vital part of the dissection, because lower down you have almost you have to almost reach up to the levator and all around without injuring any other adjacent organs, for particularly in this case the bladder, the vagina anteriorly, and the posteriorly also the presacral fascia should not be breached. In that case uh, sacral venous plexus may bleed. So continuing the dissection in the same plane, we can actually I can feel the tumor, the bulky tumor in the lower rectum, mainly on the lateral aspect. So I asked the assistant surgeon to put a finger through the anus and check the completion of the dissection, adequacy of the dissection from the perineal abdominal aspect. And now I am just dividing the mesocolon, the descending mesocolon, and actually lifting it up from the posterior abdominal wall. In that case, the descending colon will be adequately mobilized, and we can very easily do the colostomy. Now, staying just lateral to the IMA pedicle, I have started dissecting so that the IMA pedicle will come out along with the specimen. And here, before dividing, I have identified the left colic branch. So left colic branch is being divided at the root from the origin of IMA. So once the IMA left colic branch is divided, and the further dissection is being carried out till the dividing the mesocolon nicely, and till this dissection is carried out till the rectosigmoid junction, and the rectum is being dissected all around 360 degrees, so that I can fire a stapler and divide the rectum. So very gently you can see I'm just trying to identify the rectal wall. Here you can see the rectal wall, and the rectal wall is being dissected 360 degree all around. So better to do this part also through laparoscopy, because without dividing the specimen it is very difficult to take the rectum out of the abdominal wall to do this part. So here the rectum is being, the marginal vessel is being also divided, and then using 60 GI stapler, using single stapler, the rectosigmoid junction is being divided, and its blood supply is being also being divided. So a little bit of final bit of tissue dissection which was done, and once it is done, we can so now it is being divided, and the checking for the sigmoid colostomy. So this is the standard 5-port position was being used, and the sigmoid colostomy is being permanent sigmoid end colostomy is being performed. And finally I did the perineal dissection, placing the lone star retractor staying into the correct plane, so that the abdominal perineal dissection plane is being merged with the abdominal dissection plane, and the whole of the specimen is being delivered through the opening, through the perineal opening. A little bit of vagina was adhered with the rectum, which is being also divided and staying in the correct plane, and finally the specimen is being sent. This is the perineal wound which was healed completely, and the patient had an uneventful recovery. There was hardly any blood loss in the whole operation, and there was no requirement of blood transfusion. This is the final specimen, mucinous moderately deficient adenocarcinoma T3N2B LV0 PN0 M0. 19 out of 47 nodes were positive, and to my surprise there was threatened CRM. However, the patient had an uneventful recovery, and patient was discharged on post-operative day 4 on. Patient is on adjuvant chemoradiotherapy.